Hello, and thank you all for joining today on this webinar. I'm Dr. Shane Langley, and I'll be presenting on behalf of 3M Healthcare Academy on treating the mandibular arch in deep bite patients with 3M Clarity Advanced Brackets. A little quick disclosure, this is presented by me. All the slides are mine, but I'm doing it on behalf of 3M. I want you to understand, because it's very important to me, that I speak to you as a clinician, somebody who's in the trenches dealing with this on a day-to-day basis, not as somebody in an ivory tower telling you how to handle your practice and how to fix things, but as somebody who's in it just like you are. I think that's important in going forward. So. We all know that treating the mandibular arch with ceramic brackets is a bit of a controversial topic. I was trained in 2006 through 2009, and in that time in my residency at UAB, we were told not to use ceramic brackets on the lower arch due to attrition and other concerns, one being breakage, friction, all kinds of things that are a concern for us. The one thing today that's the biggest controversial topic would be lower arch bonding for fear of attrition and causing harm to a patient. But with the advances that have been made in technology, we're able to do this in a manner that's very predictable, where we mitigate any problems, and in a way that lets us set ourselves apart as a practice while we maintain safe, efficient practices. So hopefully during this course you're going to learn ways to approach the aesthetic solution in your practice. We're going to look at steps to avoid interferences. We're going to look at things we can do to prevent any enamel damage, the way that we do it in our practice when we're treating deep bite cases. Clarity Advanced has made a huge impact on my practice. We've 4 years ago transitioned to a mostly aesthetic practice. I say that because we're not 100% clear. We're about 90% clear. We still give our patients the option to choose whether they want a clear brace or a metal brace. And while we might think that clear is always aesthetic, sometimes patients feel pressured by their peers to use what they're using. So if they're in another office, for instance, that doesn't offer clarity, they may still want metal. So we offer whatever the patient would like at no additional cost to be full service, but also fully aesthetic. And it's been a very advantageous thing for our practice as far as setting ourselves apart in our area from a competitive standpoint. Some benefits to it really are practice branding. When you look at it, you become the practice in town that is concerned about aesthetics. Regardless of where we are, we know that aesthetics is very much a driver in today's market. We've seen this through our competition with regard to Invisalign and 6-month smiles and other avenues of treatment that have really exploited that, taking advantage of the fact that they know patients are looking for an aesthetic option. And yet a lot of times I see orthodontists that are slow to make changes and slow to jump on that market trend. And I think it's important to understand that it's no longer just a market trend, but it's a huge driver. So the ability to brand your practice and have that competitive advantage because you do differentiate with aesthetics is a big deal. Patients see it as an increased value. We explain to our patients that 4 years ago we used to charge more for clear, and now we no longer do so. As a value added type benefit to them, and that's made a really big change in our office. We've seen double-digit growth over the past 4 years, every year, and it seems to continue, and it surprises me. But the main change we've made in our office, the one thing we've done that has impacted us, has been this move to an all aesthetic mindset. I've also seen significant amount of or a significant decrease in our bond failure rate with APC flash-free adhesives, especially when combined with Clarity Advanced. And we'll go through the reasons for that. But that's been a very, very big advantage, and one that I think will push a lot of you towards this idea of completing your clear office or clear practices with upper and lower Clarity Advanced, not just upper. A lot of people are very apt to use it on the maxillary arch, mostly because we consider that the aesthetic zone, and the lower we don't consider aesthetic. However, we'll see today that it really is still visible as part of the aesthetic zone. And I think that we'll show that it's important from a bond failure standpoint to treat with the lower arch because it gives us better predictability from a bond failure perspective. In our office, by and large, the bond failures occur on the mandibular arch. The reason being, masticatory forces tend to cause shear on the lower brackets, which are on the buccal of the lower teeth. And when you're chewing, you tend to shear those brackets off, and they tend to be the ones that fail the most. So since we're having better luck with uh, Clarity Advanced combined with Flash Free, it only makes sense from a practice management perspective to use it on the bottom arch where that's going to be the best benefit. So our bond failure rate before we started using Clarity Advanced Flash Free brackets was about 8 to 9%. If you look at the Journal of Clinical Orthodontics, that stands in line with what the average tends to be. And if any of you follow your bond failure rates, I think you would be surprised to know that it's that high or higher in many instances. So try to track that. The way we do it is I have each of my staff members, when they're bonding brackets, just simply write down the number of braces that we put on, so we know how many braces have been applied. We're not separating it out by patient. We're just separating it out by number of braces put on. And then throughout the day, as we have bond failures, we put number of braces that have come off. And that way, there's no issue. It's strictly science. It's just math, numbers, and we look at it over across the board of a year, and we look at how many braces we put on this year, and how many braces have come off in this year, and we've been very happy and surprised, in fact, to see our bond failure rate go down to about 1%, and that saves you a lot of time, saves you a lot of money, because if you look at the cost per bond failure, JCO said it was around $150 that it costs you in time, chair time, materials, staff time to have that bracket repaired. It saves your staff stress. I don't know about you, but in our office, if a patient comes in and it's a busy time and they have a brace off, we feel compelled to go ahead and repair it in large part due to the fact that if a mother or father sees that we have a brace off and we don't put it back on, they feel as though we're not doing anything and we're hindering treatment. So we don't want patients to be upset with us, so we try to repair it. All the while, our staff feels like they're running around like a chicken with their head cut off, trying to prepare everything to get it back on. So anything you can do to reduce bond failure rate is going to be beneficial from a practice management standpoint, a staff management standpoint, and frankly, it's going to just make it easier for you to practice throughout the day and make it more enjoyable. Okay, so many reasons that we've seen bond failures reduced in our practice. One of the biggest reasons is the process we go through to etch the tooth and prime the tooth. Uh, we now use a dual etch technique. Prior to this, we were using just a total etch with phosphoric acid and transbond primer. Now we use phosphoric acid for 15 seconds on each tooth, followed by uh, transbond plus self-etching primer. Uh, the benefit to this is the redundancy in our etch. So if you get the depth of etch that you need with phosphoric acid, and you've removed that plaque pellicle that's still existent, we come back with a self-etching primer that acts simply as our primer, but it gives us the redundancy in case any contamination does occur. Phosphoric acid provides a deeper etch than Transbond Plus self-etching primer does alone. I did my master's thesis study on bonding with total etch versus self-etching primer, and what we noticed was there was a significant decrease in bond strength when you just use a self-etching primer alone. However, when they're used in tandem, the bond strength increases significantly. It's hydrophilic, so it's less sensitive to moisture contamination, and then the redundant etch is also providing you protection from contamination in the sense that if you do get contamination, it will fixate proteins and prevent bond failure. And we've seen this really reduce our bond failure rates drastically. The other thing that we're coupled with is the use of Clarity Advanced. For one, it is a ceramic bracket. Ceramics are translucent, so light can shine through them in a very good way, and that means that we're going to get more complete bonding or curing of our composite when we shine our light on the tooth. When you're using a metal bracket, you have to shine the light from many different directions, trying to get a satisfactory cure under the bracket, and we know that oftentimes we get a halo effect where the middle part of that bracket is not fully cured. So moving to a Clarity Advanced bracket, especially in the lower arch where you've got more bite force, being able to fully cure through that bracket's a big benefit. The next thing that we've done to cause our etch or our bond failure rates to reduce has been using a flash-free product. I've done a webinar before on flash-free, so I'll keep this short. But what flash-free allows us is the ability to place a bracket and not have to go back and remove that extra flash, all the while manipulating the tissue, especially on the gingival area. And when you go to remove flash, especially gingival flash, we tend to stir up crevicular fluid, and crevicular fluid will have that capillary action and kind of weep underneath the bracket and cause bond failure to occur. So with a combination of a dual etch technique, a Clarity Advanced ceramic bracket that allows full cure through the bracket, and a flash-free adhesive have been the triple threat for our office in reducing our bond failures from 8% to 9% down to 1. And that's been a huge change for our practice for the better, a big morale boost for my staff, and frankly, it makes me enjoy what I do more often. So when we look at things and we see what kind of barriers are there that keep us from going all aesthetic, from a clinical perspective, one of the biggest ones is abrasiveness, and we're unable to use it on lower arch due to the potential for attrition. So to tell you a little bit about me and where I was in this whole um, fear of attrition discussion, we were all clear for about a year before I had a patient come in that had severe attrition. And it wasn't anterior attrition, it was posterior attrition, and it was in a patient who was about a half step class 2, and they had a unilateral Brody bite, and they had some wild parafunctional habits that we weren't aware of, that we hadn't seen, because obviously we can't see patients when they're at home. But the issue we saw was that they would go into lateral excursive movements. And they started to grind their palatal cusp off. And I had two patients back to back, and it really scared me. It kind of shook me to the core, because here I am. I had made a move into an all clear arena. I loved it. Things were going really well. And then all of a sudden, I had two patients that just freaked me out. And I'm a little bit obsessive compulsive, so I really fixated on this. And I was like, I'm going to devise a way to change things. But what we did in the interim is what many of you have probably done or have done in the past, and that's we went to a situation where we were putting clear braces on the top and metal on the bottom, and we were going to use that to kind of mitigate any attrition that we had. And we'll talk about the issues with that, but I want to give you the background on where I was, at least, so that you know that I've experienced the same concern and same fear of doing so. So the purpose of Clarity Advanced brackets on the upper and lower arch is if you're going for an aesthetic model, it's truly aesthetic. So I've treated several cases with metal lower, because I went through that time period where I was afraid to do full upper and lower clarity. And the responses I would get from the patients were not all that great. They would not like the fact that it was mix matched. They didn't like how the appearance was. We as orthodontists consider the maxillary arch to be aesthetic and the mandibular arch to be hidden by the lower lip, but it's really not hidden by the lower lip. Oftentimes we'll see in static pictures that you don't see a lot of lower incisor, but you've got to remember, life is not static. Life is moving. When patients are talking and they're animated, people can see the bottom arch. And it's something that becomes something that they're self-conscious of, my wife included. I treated her, and she said, if you treat me with metal on the bottom, I don't want braces. I don't want it, because she didn't want the bottom to be visible and the top to not, and have it to where it didn't match. And I understand that. And it's consistent practice branding. It's super aesthetic. So it really does go to this next level of aesthetics. We combine our Clarity Advanced with tooth-colored wires in a lot of cases, and tooth-colored shorty ties. And I'll show you a picture in a moment. But it really does allow you a super aesthetic practice. This is just a picture, an example, if you will, of what it looks like to have a patient bonded on the upper arch with Clarity Advanced and the lower arch with Victory metal brackets. While we don't think it's a big deal, the patient sees it. This patient in particular wasn't happy with that, and we've had patients that have requested that we remove the metal and put clear on, because they want that consistency. Here's another example. You see it less on the smile, but there's still a little reveal on the lower lip where you're able to see the metal bracket, and that's not something that patients want. They want it to match, so everything looks the same, and they don't feel like they're just part of one thing and part of another on the bottom. So that consistency is important. It's something our patients want, and we have to be really acute to listen to what they're saying and what they're wanting. It's important for us as a practice in our office to provide a patient with what they want. I think ultimately we consider ourselves very much a customer service based, patient centric office. So it's very important for us to hear the patient and provide them with what they want the most. But we have to do so in a manner that is going to be uh, in their best interest. So attrition is something we have to mitigate. Here's a patient with clarity advanced upper and lower with aesthetic arch wires and shorty ties. About a 3 foot distance, you really can't tell that they've got braces on. You can see braces, but to me, it's not much different really than looking at someone with Invisalign and attachments. So it's much more aesthetic. It's much more of a blending effect with their teeth, and it's consistent top and bottom, and patients are very, very happy with this. Then you got to ask yourself the question, is this aesthetic? And who determines what's aesthetic? And we established earlier that the patient is the one who determines what's aesthetic. In this case, this is a patient who's a cheerleader, and she's getting ready for pep rally at school, and she wanted all her school colors on. So colors on clarity really pop more than colors on metal. We see our patients, the ones that are adolescents, they always want color. So the versatility that you get from this type of a product is huge. We can go from pep rally, blue and gold, one day to prom the next day where we're wearing clear ties with two colored wires. And we have that ability to switch. Whereas with metal, you don't have that ability to switch. There's no transformer that you have like in our pocket like we do with Clarity Advanced. And the parents, especially the mothers, they love this aspect. The thought of family pictures without having metal braces and color, they can have them with clear, or prom pictures that way, or the ability just to be spunky and kind of fun. So Clarity Advanced, upper and lower consistency. The patient gets to decide what's aesthetic, and you provide them with what they want ultimately. I want to show you one of my worst cases when it comes to attrition to date. And I think it'll surprise you to know that this patient wasn't treated with Clarity Advanced. They were treated with metal. So if you look closely at the front teeth, there are no mammal lines. They're nice and smooth edges and sizeable edges that have been functioned on. This bite is a tight bite. It's not a deep bite. It's just a very tight bite. From an overjet perspective, there's very little. And when we put braces on, we got metal braces. And forgive me for any saliva in the picture, but if you look closely, you can appreciate that now we've got mammalions. They're not mammalions really, but they're iatrogenic mammalions. They were created by this patient biting on their metal braces. Now, metal braces and clear braces will cause attrition. Both will do it. We don't seem to pay as much attention to metal because we feel safe with it. We just kind of let it sit there and do its thing. But we're very much opposed sometimes to clear, or afraid to use it because of the ability for it to cause wear. In this case, metal is kind of like a crock pot. It's low and slow, and it takes a while for it to happen. And a lot of times we get lulled to sleep and we're not watching it, so we don't really see it till it's too late. And clarity or ceramic is more of a microwave. We're going to get that attrition more quickly, and you got to be very aware of things from a visit to visit basis, and you need to plan for things in the future so you know what's going to happen next. Orthodontics, by and large, is like a chess match. We want to stay 2 or 3 steps ahead of where we are. We want to make sure that we're ready for everything that's going to come our way and mitigate problems before they actually occur. So this is just an example of a kid with a 100% deep bite. He was treated with a forceps, um, and he was treated with Clarity Advanced, both upper and lower arch. So one thing to consider on these cases, when we see buccal segments that are a half step class 2 or more, um, we think we're worried about attrition only in the anterior, but we also need to worry about attrition in the posterior. When we start to correct that malocclusion, and those cusp tips are kind of walking past the brackets on the bottom, there's potential for them to flatten out and to wear. So we need to watch that. It's not the aesthetic zone, but it's still tooth structure, and we want to prevent that and protect it nonetheless. But this guy was treated with a forceps. Here we are close to the debond. And I want you to see there's cusp tips everywhere. We haven't worn off our buccal cusp tips. We don't have attrition on the anterior teeth. We've fully opened our bite. We've gotten to a point where we've got a good result, and we're going to finish him with forceps and with Clarity Advanced upper and lower. Here we go at the end. final result looks good. He's class 1. He's got his bite open. There's no wear. Everything's nice and aesthetic. We've caused no harm. We've given him aesthetic treatment all the way through. Aesthetics shouldn't just be the final outcome. Aesthetics should be from start to finish. We should always be aesthetic. This is another example. This is a patient that's a 3/4 step to full step class 2, 100% deep bite. We treated her with a forceps as well. And here we see towards the end of treatment, you can see full expression of my reverse curve or my bite opening curve wire in the lower arch to help open that bite. One of our biggest things we do to correct a bite is to get that lower arch leveled as soon as possible. In orthodontics, I look at it kind of like a chemical reaction. All chemical reactions have a rate limiting step, and that rate limiting step in orthodontics is pretty much always, at least in the bulk of our cases because they're deep bites, is leveling the lower curve of SPE, getting that bite open. And that's one thing that we try to approach quickly, get the bite open as quickly as possible, because that lessens the amount of time that there's potential for attrition, and it gets us to a spot where we can actually move forward with treatment faster. So opening the bite is extremely important. But to go from this instance where we're a half step to, 3/4 to a full step class 2, 100% deep, to a point where we've got good aesthetics, good bite, all treated with Clarity Advanced upper and lower, and a forceps appliance. Oftentimes people ask the question, are you comfortable treating with a forceps with Clarity Advanced lower arch, because the push rod butts the bracket, so they're afraid that that metal to ceramic interface is going to cause damage or break the bracket off. And actually, we have not yet to date had one brace come off where the push rod and the bracket contact. And what we do to use that in our favor is we take a bumper tie, which you'll see later in this presentation, but it's an O tie with a bumper. You can get it from your 3M rep, and we place it under the wire, and we turn the little bumper so that it's facing distally, so that the little push rod will touch that rubber, and it's a shock absorber, so it really breaks the force down, so that you're not going to have that metal to ceramic connection. So it kind of gives a shock absorber effect, and we've not had one bracket come off yet. Again, our bond failure rate, the bond strength with Clarity Advanced, Flash Free, Dual Etch is significant. So we don't see a lot of bond failures, and we don't see a lot of bracket breakage during forceps treatment. So it's absolutely usable for forceps treatment, for surgery cases, for everything. So I want to talk a little bit about what we've instituted in our practice. And this is by no means going to be all encompassing, and there's always multiple ways to accomplish an objective. But this is the solution that we've seen in our practice that's worked. And I break it down into a small little cookbook of things for you to do to implement in your office that are going to allow you to go completely aesthetic without any fear of attrition and that you're doing something to harm your patients. We'll go step by step. So first thing, we used to always bond upper and lower arch from day one in 99% of our cases. And now I'd say we bond more patients in the upper arch only for about 3 months to allow the depth of bite and the overjet to increase, the depth of bite to decrease and the overjet to increase, to provide better clearance for these lower brackets. Now, we don't do this in every instance, but we do it typically in class 2 div 2 cases where the upper incisors are retroclined and they're up against the lower incisors, or 100% deep bite cases where we feel that we would benefit from rounding out the upper arch first. I don't feel as that slows us down at all, because a lot of times the issue with lower arch unraveling or correction of lower incisor crowding is in part due to the fact that we have no real overjet, so there's nowhere for those teeth to go. So it takes a long time to open up, to round out our lower arch. What we've noticed is by going ahead and rounding out our upper arch, creating a good bit of overjet, when we put bottom braces on, they tend to move rather quickly. They have room to move. There's places for them to go. They're not bound down by the lack of overjet. So teeth move pretty quickly. We usually leave them on for 3 months, 2 or 3 visits, depending on how severe the deep bite is, how much we need to increase that overjet. If you want a rule of thumb, I would say the visit that I go into a 1925 nitinol, a rectangular nitinol wire, that's the visit that I'll typically bond the lower arch. By then I've leveled the upper arch sufficiently and have gotten enough correction to where I feel comfortable putting the bottom braces on. This is the biggest thing in our office that has helped us mitigate attrition. and this is just simply a discussion that we're going to have on bite blocks. Some patients like their, or some clinicians like their bite blocks on their sixes. Some like them on their first bicuspids. Some like them on anterior teeth with a bite turbo. Personally, I've come to love bite blocks on our upper fours. I think they provide us a great benefit, and I'm going to go through all the details of why. I'm going to go through step by step how we place our bite blocks and give you some real good benefits. First off, to talk about the other options, bite blocks on our anterior turbos. Um, my biggest concern is that we disclude the posterior teeth and provide no chewing surface for a patient to bite. Sometimes we have posterior open bites that we create that are upwards of a centimeter, and that's significant. I had an instance in residency where my best friend had placed bite turbos on a patient with a 100% deep bite. He was left with a very large posterior open bite, and went to have dinner with his family. They had steak. He would cut it and chew it to the best of his ability, and then swallow it, and it got stuck in his esophagus. He had to go to the ER and have an endoscopy to remove the chunk of steak, and that's something I don't want to see happen. I don't like that liability. So I'm not a big fan of bite turbos. Another reason I don't like them is oftentimes our overjet is too great, and you can't make a bite turbo that's long enough to actually disclude you and keep you protected. And then the next reason is I've seen lower incisor attrition or wear from bite turbos. And whether we see enamel wear on the lower incisors, the upper incisors, or the buccal cusp of your posterior teeth, attrition is still attrition and is damage to enamel, and I want to prevent that. So I've really shied away from bite turbos. Um, Upper six bite blocks. Uh, the reason I'm not a huge fan of upper six bite blocks is twofold. One, if you're familiar with the wedge effect, the wedge effect being if you change something in the posterior 1 millimeter, we'll see a 3 millimeter change in the anterior. That's beneficial in a lot of ways. You can put a very thin bite block back there and get quite a bit of disclusion in the anterior. The problem with that is the what helps you, it also harms you. If a patient goes home with a bite block on their upper six and there's any wear on the composite or intrusion of the molar, we're going to see a pretty quick change in the front. So, say they wear their bite block by 0.5 millimeter in their 6 or 8 week interval visit, and they come back in. Now their anterior has closed 1.5 millimeters. So, we might have had a millimeter of disclusion in the anterior, but when they come back for their second visit, they're now biting on brackets. So it doesn't provide me with long-term safety of disclusion. The next thing is it keeps me closed in the back. If you ever get to a point where you finally can take off your bite blocks, you take the bite block off and the bite's going to close down, and you're going to be deeper in the front. So it's almost hard to ever unmarry yourself to this bite block on your posterior teeth. I found that bite blocks on the upper first bicuspids have been a very nice combination of the two. They're more anterior in the arch, so we reduce the problem we have with the wedge effect. So we're not getting the 1-to-3 ratio. It's more like a 1-to-1 or so ratio of change. Um, so it's more forward in the arch because it gives you a little bit of what the bite turbo gives you, but it also gives you posterior occlusion. You can still grind your food. You have those teeth in the middle that can still pulverize food a little bit better. It also allows me separation in the back, which I love. One of the things I like about a bite turbo was the fact that it did give you some disclusion. And if we ran early class 2 elastics, you can get eruption of the molar, which helps open the bite, and you can get forward movement of that lower arch, which gives you class 2 correction. So you get a little bit of that. Also, since we have that disclusion that can be closed with elastics, once I have posterior contact with my 6s and 7s, I can take the bite block off safely and the bite doesn't deepen because I've got posterior contact now. So it's been great. Another thing we've seen is early class 2 correction. It actually mimics a labiolingual guide plane, and I'll show you that in just a second with a case. So here's a guy. He's a deep bite, 100% deep bite, a lot of flare in his dentition. So when we do our bite blocks, we do it this way. I take some tray paper, and I have my staff members cut that tray paper into quarters, and they keep tray paper, a stack of it, in their drawer. So it's there at my disposal whenever I bond an arch. I always bond the lower arch first, and then I evaluate where I need to have how much disclusion I need and what I need to how much I need to open that bite, and I'll fold the tray paper accordingly. So I'll fold it, and I'm basically creating a disposable leaf gauge made out of paper. The leaf gauge is just something you can increase the thickness a certain amount to however much you want, and have the patient bite in the anterior, and it discludes the posterior. So this is very customizable. I can bend it and fold it however much I need to get that thickness. And that's going to allow me to get the disclusion that you see through the posterior teeth right here. We etch the palatal cusp. I just do a 2 millimeter roughly etch with phosphoric acid for about 15 seconds. Rinse that off and dry it. We get to that point where you get your little etched surface right there. We then place LPOP, or transbond self-etching primer, we call it LPOP, on the whole entire surface. So I know I'm getting my etch from my phosphoric acid, and then I get very light etch from my self-etching primer on the whole surface. That way I seal my composite down. And I want that seal. I think that's important to make sure I don't get any leakage and staining or cavities during this time period. Then I mound up composite. Just take some transbond and mound it up, and then have the patient bite into your leaf gauge, and we're going to shine a light on the composite. So now it's automatically equilibrated because they're biting down, and you're curing both sides, and you don't have to worry about whether or not you're hitting on the right side more than the left side. So it's very beneficial and quick in that manner. And that's what we're left with. I come back in and I clean it up with a diamond burr. I just want to flatten out the fossa a little bit. I don't want that to be something that is so deep that we have a lot of interferences when you try to move laterally or forward. I want to free that cusp up, not to be bound down into that fossa that we've created in composite. And I want to make it comfortable for the patient. So that's what we're left with. And then here we are. We have disclusion. We're not hitting on any anterior teeth. When we look at the buccal segments, though, the neat thing I see that I really love is this vector that's being created right here with this interaction. And that's the cool thing, is that interaction is on an inclined plane with those cusps, which is going to provide us with two vectors of force. And then the resultant vector is one that pushes lower teeth down and forward, upper teeth up and back, and it's class 2 corrective. So we've noticed that we have early class 2 correction in a lot of these cases. This works for anything that's a half step or less class 2. Once you go past the half step, then we no longer have that benefit. And in those cases, anything past the half step, we're using a forceps for our class 2 correction anyway. So we don't need that added benefit. There we go. Same thing on his left side. He's got clearance, and you can see that we have clearance in all aspects. So what I've got here is a video, and it's a video that shows this in action. It takes about 3 minutes, so bear with me, and I'll walk you through everything that we're doing, but it shows me folding my leaf gauge and going through the entire process of applying these bite blocks. So you fold it to your desired thickness. You try it in, and you have your patient bite back in centric. Now, the hardest thing sometimes is to get a patient to bite back in centric. They want to bite forward, so you got to make sure you train them. We call it home base. I'll say, go to home base, and they'll bite in home base. Then we go in, we're going to etch, like I said, just about a 2 millimeter etch on the palatal cusp. Now, one thing that I'll do in cases where there's an amalgam or a restoration of any sort, whether it be composite, I'll etch the buccal and palatal cusp tip just to kind of hug that tooth together, so you don't want to have any kind of force that's going to be splitting on that. So if I feel like there's a restoration and I want more support, I will etch the palate and the buccal cusp, but I still only spot etch, and that's something we do routinely. You just rinse it off, and then we come back after we dry it, and we apply our LPOP on the entire surface. And you'll see this process goes relatively quickly. We can apply them in about 2 minutes. And it's quick. So LPOP over the whole surface. We'll come back in with some composite, place it on the tooth, mound it up really nicely so that it's where I want it, and high enough that when they bite into that paper in home base, then it really depresses over the cusp tip. Here we go with our leaf gauge. Patient bites in home base, and we can see on the right side there we get good disclusion. So now I shine my light while they're staying closed. I instruct them not to open until I tell them so. And we'll tack cure for about 6 seconds on each side. and then I have the patient open. The composite stays there, and then we go in and final cure. I'll give it a full round of cure from our light on both sides to make sure that it's nice and set. Um, we don't have these come off. I think the fact that it's well adapted to the tooth and the forces of occlusion are not shearing; they're actually just compressive, are beneficial. We don't see these come off or debond in our offices, so I feel very good that they're going to be there for a long term. And then now we'll go in with our diamond burr and we'll just kind of smooth out that fossa. You can see how that fossa is accentuated, and what we get there essentially is a locking in of the lower arch if we leave it like that. And as those teeth move, remember this is uh, the day we're bonding the lower arch. As teeth move, they're going to interfere and hit that fossa funny. So we want to make sure that it's more of a flat surface, as flat as we can really get it. You always leave the depth of the fossa. That's your contact. So you can take out all the lateral portions, but leave that depth of the fossa in place because that's our positive stop. And then once we get that, we just kind of round out the palatal, make it smooth so they're not having anything rough or sharp that bugs them. And then you'll see in a second that we'll have good disclusion. When the patient bites together, they feel like they're hitting on both sides. We always ask, do you feel like you're hitting both sides evenly? Uh, and they say yes. And if they don't, then we'll correct something. But 9 times out of 10, or even more than that, you're hitting perfectly on both sides because we use a leaf gauge. So there's our disclusion. Patient feels good, and we're done. So it's really that simple. All right, so we saw a video on how to place these bite blocks. I wanted to show you how simply are removed. We simply take a flame-shaped finishing burr. I drill into the bite block and just twist ever so slightly, and it comes right off in one piece. You don't have to go in and grind and remove uh, like you do with the blue goo that you might put that goes into the pits and fissures, and you have to kind of cut it all out. This is such a nice technique in the sense that it's very easily removable, makes your life easy, and makes it much easier for the patient to tolerate. So here's a video just to see how quick it goes. So drill in, twist, and it's done. And then I go back and make sure that there's not any like leftover little pieces that are bonded to the tooth. But that's it. It's that simple, and hopefully that technique alone will help you prevent deep bite attrition and make you feel more comfortable. That is no doubt the most important thing we've changed in our practice that's given us comfort in using ceramic brackets on the lower arch. So my wire sequence, just so you can know, everybody tends to ask like, "What's your wire sequence?" Is I like a 14 super elastic night tie. It stays in for typically 12 weeks. We do 6-week intervals on most of our patients, and we will keep it in for 2 visits. We use figure eight that tie, and that does great. That is the only super elastic wire I have in my office because I want super elasticity when I'm getting rotations out. But when I begin to level an arch, I want more stiffness. So we go to a classic. So my next wire is an 18 classic night tie. Leave that in for 6 to 8 weeks. Sometimes in that time frame, we'll do an 8-week interval. And then we go to a 1925 night tie. If it's a deep bite, we go to a reverse curve, and I'll show you that in a second. We call it the Pringle wire, so I'll just tell the staff, hey, get a Pringle, and they'll put it in, and that helps me open the bite quicker. So remember, the rate limiting step in our chemical equation of orthodontics is leveling that lower curve. So I'll put a reverse curve in pretty quickly. And then 925 steel, reverse curve if it's deep. Once again, that's my working wire. And then I finish on an 18 stainless steel typically to let things settle in and just kind of finish up. It's easier to make adjustment bends in an 18 steel if I need any little small adjustment bends, and it works really well. The next thing that we want to talk about when we're talking about treating these deep bite cases is the use of that elastomeric ligature. And when you get it from your 3M rep, I think the name of it is elastomeric ligature with guard. We call it a tooth pillow. People call it many different things, but bumper tie, whatever you want to call it, but they'll understand what you're talking about. And it really helps to prevent occlusion on a cusp tip. So looking at this picture, this is the patent picture. That's really some of the only pictures I could find that were good. It's essentially an O-tie with a bumper on top of it. It works great. One thing I want to warn you against is do not use it as a ligature. Do not use it to tie your wire in. They don't hold as well, so you're going to have issues with that. We use it underneath the wire, so I put it on first, and then I put the wire in, and then I put a figure eight tie over that. One of the wonderful things about Clarity Advanced has been the under-towing undercut. We have plenty of space under our tie wing. I can tie 3 things in at once. And that's not the case with most ceramic brackets, and it's definitely not the case with ceramic brackets in the past. They were bulky and didn't have a lot of room to tie things in, so you had to change your mechanics. Well, Clarity Advanced has allowed me to maintain my mechanics that I would normally use with a metal bracket, so we don't treat any differently in that bracket. Putting it on under the wire, we make sure that the bumper is at the top because we're wanting to prevent contact with our incisal tie wings. And then I put the wire in and figure eight over that. This is a case where we have a deep bite. You can see my bite blocks. They're pretty substantial. We bonded the upper and lower same day. Bite blocks on both sides. And then you'll see when I open up, right here, these are clear, so they're hard to see, but here's my O-ties sitting on top of the bracket to prevent any incisal contact with the upper portion of that if they come into any excursive movement. Here's some on the buccal segment. We talked about wanting to protect the buccal cusp when they're coming in contact. So here's my tie on the buccal under the wire, figure eighted over it. Now these only come in 2 colors. They come in clear and they come in silver. We prefer the silver because it stains less, so it's not as obvious and it stains less and it looks good. Here we are with the patient without them in. You can see how deep their bite is and how I'm concerned about that. So we will come in, put these little bumper ties on, and now we're not going to have any interference. The rubber pillow protects the tooth from attrition. And you can see also in this picture, I put bite block material on the E. A lot of times I'll do that if I have an E that's still present for 2 things. It gives me disclusion, and it also helps to kind of loosen that tooth with time and work it out. This is an occlusal picture of a patient with bite blocks, not bite blocks, with bumper ties on these lower incisors. And you can see how nicely it fits over those incisal tie wings. Next thing we do is we really want to start bite correction as early as possible. So we bond our lower 7s. We consider bonding lower 7s a bite opening move. Gives us more posterior support to intrude our lower incisors and correct our curvus B. So we start that with reverse curvus B wires as well. And here's that reverse curvus B wire that we discussed. 3M carries this. It's a great product. It works extremely well. Again, we call it a Pringle because it is shaped like a Pringle. The thing I love about this is it's bent in a manner that mitigates your tendencies for the lower to roll outward. So since we're using a reverse curvus B, you're having an intrusive force on your molars, but it's buccal to the center of resistance. So that tends to roll your molars out. Well, if you look at this wire, it constricts towards the posterior. It broadens in the bicuspid area because we have an extrusive force on our premolars. Again, it's buccal to the center of resistance, so that tends to roll your premolars in. So this wire is made in a way that mitigates all those side effects, and it gives you nice bite opening correction. And then don't consolidate your upper arch. Don't do things that are going to lessen your upper perimeter because that's going to bring you in contact with those braces before the bites open. So we will consolidate our 2 to 2 segment, and we'll consolidate our buccal segment, and then we wait until that bite is open all the way to close the upper arch. From a mechanical standpoint, this just makes sense because if we have lower contact and we're trying to correct a class 2 and we have anterior contact, we're going to end up dragging our upper buccal segments forward anyway. So I prefer to hold off on my my anterior space closure until after I've opened up the bite and corrected my class 2. Now, we keep our 2 to 2 segment together because patients don't like spaces in their front teeth, but they tolerate spaces between your laterals and cuspids very well. That hasn't become an issue. So don't reduce your perimeter on the upper arch when you're in a deep bite situation, especially with Clarity or ceramic, because that's going to tend to pose a problem for us and put us in a position where you're going to have more contact that's unwanted, which can lead to more attrition. And then lastly, educate the patient on the importance of coming to be seen if they experience any anterior contact or contact with braces. Patients know better than we do sometimes when they're hitting something, and they can tell when it's normal and when it's not. They can tell when they're hitting a brace. So I explain the importance of the need for them to come in and let us know, hey, I'm hitting a front tooth on a brace. I need to be seen, and we'll get them in quickly. What we tend to do in those instances is add bite blocks. So I'll just either take my bite blocks off and add some ones that are a little bit taller, or sometimes I'll even plasty on a bracket. Like there's ways to take a little bit off of the ceramic with the diamond burr, still be able to tie everything in nicely, but get them out of contact in those teeth. But we want to make sure we address that quickly, and my front staff know that's considered an emergency, not to push it off. It's something that's considered necessary to see them now, because I don't want to have an issue with the front tooth getting chipped or something like that. So that works extremely well. Okay, so this is our informed consent form that we changed. We actually made a modification to the AAO's form. If you're like me and use the AAO's informed consent and you've read it, you'll realize that their section on clear braces doesn't cover anything regarding attrition. It only covers potential for breakage of teeth upon removal. If you're comfortable or aware of Clarity and their history, you know that 3M has always created ceramic brackets that are easily removed. They're highly touted as being easily removed. They're made to infracture on themselves. There's a weak spot in the vertical aspect of the bracket base that allows these brackets to break inward on themselves. They fail at the composite to ceramic bracket interface, not the composite to tooth interface. So you're less likely to break a tooth when it fails at that junction. I've never really had a concern of breaking a tooth while taking off a ceramic bracket because they come off so easily. So when I was reading that part of the informed consent, I realized this isn't really what I'm concerned about at all. And what I want to inform the patient of is the potential for attrition, because that's what we're talking about today, is how to prevent attrition. And one of those ways is to fully inform a patient. And then also, if there is attrition, I want to be sure that I have informed them so they were aware of it. So we changed our informed consent to read this way. Ceramic braces on the lower teeth may cause wear of the opposing teeth if in contact, or if the patient is a heavy grinder or has parafunctional habits not seen at the initial examination. If you ever feel as if you're touching braces at any point during treatment, you should let your doctor know as soon as possible. Enamel wear can also occur if the patient does not attend regular appointments and remains unsupervised. If damage to a tooth does occur, enameloplasty, which is reshaping, and/or restoration of the involved tooth may be necessary. So what we do in this instance is every patient who decides to have clear braces, of course, in the informed consent, we have them come through and initial this particular paragraph. At first, I was afraid that it was going to be a deterrent to people getting clear braces on the lower, but it hasn't changed anything. In fact, nothing's changed. They still get them at the same rate, 90% clear, 10% metal, and this has never been a point of contention where a patient decided not to get ceramic brackets. So I feel as though this isn't going to protect me completely, but at least I'm giving them all the information. What we get in trouble mostly for is withholding information or not fully informing someone. And now I feel like we're fully informing them and educating them on all the aspects of ceramic bracket choice. With that being said, in our practice, within the past 2 years since we've instituted all of these, I haven't seen attrition. We haven't had it. It hasn't been an issue. We've found ways to mitigate it, and I really feel as though if you apply the things that I've just discussed into your practice, and you're very good at watching it and discussing it with your patients, you're going to avoid attrition and be able to have a fully ceramic practice that's able to differentiate itself, set itself apart, brand your office in this way, provide patients with what they want, and which is great value, and something that is going to really change your practice and the way that you practice. But you've got to apply all these, and you've got to do it very diligently. So lastly, this is my daughter, and I want to express to you, I'll have patients who come in, and I know you all do too, and they'll come in and say, well, what would you do on your daughter? Or what would you do on your kid? And that's a very important question that we should always ask ourselves. What would I do on my child? If I wouldn't do it on my child, then I probably shouldn't do it on your child, their child. So it's something that we're forced to become introspective when we treat our own children. If you look at my daughter, she's a 3/4 step class 2 on her right side. Cusp tip is way past halfway. 90% deep bite. Half step class 2 on the left side. And I treated her with Clarity Advanced. So I put the top arch on first. You can see my bite blocks. that are existent on the upper floors. We leveled it out for about 3 months. We're in a 1925 nitinol. You see that I'm chained upper 2 to 2, and the buckle segments are left figure eighted. And I've got this is the day we put the bottom braces on. I have tooth pillows on her lower incisors. You can't see them, but there's little tooth pillows there just in case, because those are the only teeth that are close to contacting. If she comes forward, then she may touch. But that's again trying to mitigate any parafunctional habits that exist. But this is my daughter, and I very well put clarity on her, and she loves it, and she changes her colors out all the time, and she and her friends are always discussing what colors to go on with next. And it's been an amazing thing for her. And we haven't had any attrition, and I don't lose any sleep at night. I'm not constantly checking her teeth to see if there's attrition. But again, if I would do it on my daughter, I would hope to say that I would feel safe doing it on anyone. And I'm not just up here talking about something because I've been asked to. I'm talking about it because this is a huge part of our practice, and it's changed our practice in a way. And if I can share any of that with you, any of that knowledge, I'd be more than happy to try to help you improve your practices, help you to experience a branding, a rebirth of a practice that may be starting to decline or stale and plateauing. There's so many reasons to move into this arena, and I don't want bonding clarity on the lower arch to be what holds you up and what stops you. So if you have any questions regarding any of this stuff, feel free to reach out to 3M. Your 3M rep will have my information, my contact information, and I'll be happy to share our informed consent changes or any just questions you may have in general about what you just heard. I know about an hour is not enough time to really dive in there and correct it, and I haven't been able to answer questions. So feel free to reach out to me personally, and I'll be happy to answer anything that I can. I hope the best for y'all. Again, thanks for listening, and I just want to say thank you for everything.